Hi, this is Matt Hartman from Pittsburgh, PA. From the RadPath channel today, we'll be talking about the esophagus. Again, the individual lectures can be found on the ACR building block site. And if you want to check out our Anki Deck RadPath flashcard, check out the About section for the YouTube channel. A little bit of review of the esophagus. Remember, it's a hollow muscular tube from pharynx to stomach. We have outer longitudinal and inner circular muscle layers, have stratified squamous epithelium for the upper 2/3 and columnar epithelium for the lower 1/3. That'll be important when we talk about the pathology. The upper esophageal sphincter complex includes the cricopharyngeus muscle, and the esophagus is approximately 25 centimeters in length. It's located within the posterior mediastinum, and it enters the abdomen through the hiatus at approximately the T10 level. How does it look radiographically? Well, at rest, it's collapsed. It's difficult to evaluate when it's collapsed. When we do fluoroscopy, we'll do double contrast where we administer effervescent crystals, puff up the esophagus, make the patient feel like he or she has to burp with lots of CO2. And then we give them oral contrast in the form of barium to coat the mucosa and get some nice 3D pictures. Normally, the esophagus should be smooth and featureless. A great advantage of fluoroscopy is we can study peristalsis. This is a big advantage we have in radiology over the our endoscopic colleagues, who, when they do endoscopy, the patient's basically knocked out. But when we do this study, the patient is awake, we have them lying down, so gravity is out of the situation, and we can really see how the primary peristaltic wave is moving that food bolus. And it is also great for looking for reflux. So the normal CT appearance, so if we're doing CT chest, the esophagus should be collapsed. Again, tough to evaluate in the non-distended state, but we'll see some examples of really thickened esophaguses and really dilated. So this is what the esophagus looks like. This is single contrast, just a column of barium. This is double contrast to give them the fizzies. CO2 is produced, puffs it out, and then give them some barium to coat and get a nice 3D appearance of the esophagus. And this is what the endoscopists see. Again, just a big tube, different ways of seeing this tube. Again, reviewing the 6 patterns of a tube. Go check out the Intro to RadPath lecture if you haven't seen it, but we have a tube, mouth to anus, one of 6 bad things that can happen. Any, an outie, a narrowing, dilation, thickening, or displacement. Innies project into the lumen, outpouchings, outies project outwards. We'll see examples of those. Narrowing and dilation along the course of the esophagus, and displacement, something pushing or pulling the esophagus. So let's see examples of these. So case number 1, 58-year-old male presents to the PCP with heartburn. We do the double contrast esophagram, and it looks like Cookie Monster took a bite out of the esophagus right there. There's something in here taking up space where the contrast is not going. This is going to be our innie, just above the GE junction, highly suspicious for malignancy. And we do a CT, you see it's abnormally thickened there. PET CT, FDG avid there, and our endoscopists see a big innie projecting in. What is this? Well, we're worried about malignancy. Esophageal cancer, again, this is where I said histology will be important. Squamous cell in the proximal 2/3, or this example in distal 1/3, adeno-CA. Case number 2, dysphagia halitosis. We do the esophagram and we get an outpouching in the cervical esophagus. The endoscopists go in and they see the same thing, an outpouching off of the off of the lumen. We have the Zenker's diverticulum. This is a pulsion diverticulum, occurs above the cricopharyngeus muscle. It's a false or pseudodiverticulum, not all of the layers, but can present with halitosis, regurgitation of undigested food. And the lateral view is key for making this diagnosis. Okay, persistent reflux, case number 3. So we do the scout radiograph in all these patients, and the astute observer might see a lucency right behind the heart. You give them the contrast, determine the milkshake, turn them all around. Some of the contrast comes up, part of the stomach comes up. So there's our retrocardiac lucency. And this is our CT correlate with about a third, maybe a half of the stomach having an intrathoracic location. And this is what the endoscopy colleagues will see. Basically, this is a big hernia. And you can think of this as a displacement. The stomach gets pulled up into the chest. So large hiatal hernia. Case number 4, no mediastinal mass, but a patient with dysphagia. Food's getting stuck. Let's do a double contrast esophagram and see. Nice area of narrowing, pretty smooth. Our single contrast, see that as well. The contrast makes it through though, so not completely obstructive. So really an area of narrowing. What's narrowing it? We'll do our CT, and we see a mass-like lesion in the subcarinal region. And on endoscopy, you see extrinsic narrowing of the esophagus, something sort of like the ball under the rug growing in, causing that lumen to be narrowed, a little bit displaced, and also the walls being looking like it's being thickened by this mass. So remembering the esophagus is a mediastinal structure. We divide the mediastinum into the anterior mediastinum. We remember the 4 T's. The middle mediastinum, that's lymphoma, every differential. Bronchogenic cyst is something that likes to be in the middle mediastinum. And then our posterior mediastinum, again, lymphoma, neural crest tumors, neuroenteric cysts. And of course, our esophagus being a mediastinal structure as well. Case number 5, progressive dysphagia for the past 6 months. We always ask, is it with solids? Yes, but now also with liquids. Regurgitation of undigested food. That's a key part of the history. So we do the esophagram. This is after 10 minutes of eating ingesting the contrast. Normally, it will go down within 3 seconds. Again, this is actually standing upright, so gravity doing its best to help, but the food's getting stuck with some bird's beak narrowing right at the GE junction. This is the correlating CT, again, a air-filled mediastinal structure right to the level of the GE junction. Our annotations. And again, this is on the building block site, so you can go back, take a look at these slides, take your time with it. What I really want you to get down is the patterns. Here's a nice lateral radiograph. Again, esophagus is air-filled. Normally, we don't see it this well. The fact we're seeing it tells us it's dilated. Here's a nice CT correlation from the sagittal. A big time dilation, and we saw the narrowing at the GE junction. This, of course, is a case of achalasia. The bird's beak narrowing is classic. It is a failure of the LES, lower esophageal sphincter, to relax. Absent peristalsis, food gets stuck, can present with chest pain, regurg, and can be, so a couple of mimickers here. Of course, we always worry about a malignancy right at the GE junction. Scleroderma, connective tissue diseases can impair peristalsis and can look somewhat similar. Often scleroderma will have a patchless esophagus, get strictures later, and oftentimes you'll have chest pathology as well, and hopefully you have that clinical information ahead of time. But the pattern can be the same and can potentially be tough to distinguish. Okay, case number 6, patient with multiple medical comorbidities, postpartum cardiomyopathy, severe dysphagia, and chest pain with swallowing. That is a very complete history. We often don't get that complete a history. We're going to do the esophagram double contrast, and instead of being nice and smooth, what do you guys notice here? Well, this looks lumpy bumpy, very reticular, not normal. What could this be? Do the endoscope, and a bunch of irregular innies on the inside, sort of an erosion, sort of whitish, like some edema, ulceration, very ugly. This is a case of esophagitis. It can be inflammatory or infectious. Patients who've received radiation can get esophagitis, chemotherapy, immunosuppression. Now, with the immune therapy, it can cause itis of anything, including the esophagus. And clinically, it's going to present with dysphagia, chest pain, and if untreated, stricture and possibly bleeding. Okay, our challenge case, lifelong dysphagia. So this is a patient. We do a single contrast, and notice the esophagus should be coming straight down, but instead it is displaced to the left. What's causing it to be displaced? Well, if you've done the chest modules, Red Felson's, you might remember the moguls were supposed to have on the left side the aortic knob and the pulmonary artery, but this one, we have the knob on the right side. And we have a right-sided aortic arch, which is causing displacement of the esophagus. So esophageal displacement, we saw a nice example there. You have to know the normal course of the esophagus, anything pushing or pulling. So vessels, tumors can all push or pull the esophagus. Right-sided aortic arches may be asymptomatic, like our case, or can present as a vascular ring in a newborn, causing esophageal tracheal compression, and often can be associated with cardiac malformations. So, in summary, the esophagus, think of it as a big tube. 1 of 6 bad things can happen to the esophagus: innies, outies, narrowing, dilation, thickening, or displacement. We try to make a differential diagnosis based on the finding and to help our GI colleagues know where to go for endoscopy to make the definitive diagnosis. And remember, one key thing, one thing where we really add a lot of value with fluoroscopy of the esophagus is motility. And remember that achalasia case. And oftentimes more subtle cases of dysmotility where radiology will really add a lot of value for those patients.